Good morning, all, and very happy Sunday to everyone. Thank you for choosing to spend.
Different countries. Nephlearn is not just another learning platform. It's a space meant to make nephrology more interactive and accessible. Nephlearn is the ultimate learning partner for dialysis professionals. Whether you are a dialysis technician, dialysis nurse, or a nephrologist, this is an amazing platform. It is a content designed to enhance your expertise and keep you at the forefront of renal care with interactive modules, real-world insights. It's a perfect tool to support continuous learning and professional development. Subscribe Nephlearn on YouTube channel. Upgrade your knowledge to the next level. ये just ऐप नहीं है, ये ऐप नहीं है, ये आपका नया पोस्टर है in the world of nephrology. So we have many subscribers on YouTube, even on Instagram. तो चलिए डाउनलोड करिए, एक्सप्लोर करिए नेफलर्न ऐप और बन जाइए co-star superstar of nephrology. Next shout out to our ATO, Dr. Ashwini Gopalkar. She has been an administrator for last 25 years of nephrology. She is a pathologist. She is a qualified auditor for Dialysis Center Accreditation Standards, and she is a member of Technical Committee of the Standards. She has been author for chapters in the Handbook of Dialysis for Technicians, published by Central Indian Nephrology Society. She has been a faculty for certificate courses, diploma courses for dialysis technicians. She is a founder of Nephlearn, India's first app for dialysis technicians. So put on your virtual seatbelts because this session is ready to take off with the style, swag, and there's a dedication. I request Dr. Ashwini Kankar to start this program.
Good morning, everybody. Thank you, Priya, for that wonderful session, and thank you for sharing your wonderful insights about Nephlearn. Actually, I didn't know Nephlearn is so much till today, and thank you so much for that lovely introduction. But today, our team, as usual, has been trying to engage learners of nephrology, especially dialysis field, with the different offerings. And you have already mentioned the YouTube channel, which has so many podcasts, which has so many webinars, which has so many other interesting things to look at. But today, our team has been working for the last 3 months, which is why we've been so silent, and we have created this game. So let me tell you what gamification means actually. So you all must be using Zomato or Swiggy or something similar. And when you order food and it says that, okay, if you order above a certain amount, above maybe 499 rupees, you will get delivery free. That is gamification, which is surprising to know. What we think as a game is only that you click and you put maybe Mario, like Super Mario, you help Mario to cross the obstacles and things like that. But that's not only gamification. Gamification engages the learner in such a way that he is able to overcome his learning difficulties, and it gradually motivates you, inspires you through little benefits like maybe coins,
maybe stars, maybe a trophy. And in our game, what we have done is a small, cute kidney, and the kidney is very ill at the beginning. And as you solve the case, it becomes happier and happier until it has stars in its eyes at the end of the game. So let me tell you more about this. And let's take a small preview about this game. It's free to play and it's our first offering, so we would really like genuine feedback about it. Some of our beta users have already seen it, like Priya, like Lokinder Sharma, and they have given excellent feedback, which we had incorporated in made changes into our game. But I would like more of you to come forward, maybe with even creative ideas. For example, one of the ideas that we have is to create a dial circuit for the board for CRRT machine, and then you will be given instances where maybe the patient's BP is now dropping or the urine output has improved, and what are the changes in the various dials or the prescription of the dialysis that is going on that you would like to make. Just a few thoughts off my head, and we are going to work steadily in this direction, and I hope more of you come forward, help us, join us, enjoy the process. So now, very briefly, let me show you the game preview.
Here's the game, the front screen, where it shows three buttons: start game, information, and credits. In information, you will be given few instructions, and the main objective of the game is to treat the patient. I would like to give credit here to those who helped build this game, and that is our graphics designer Jay, our technical advisor Aditya, and developer Sandesh, and of course Dr. Dhananjay. Now you can start the game, and first you will be asked to register your name and email ID so that you can receive a certificate. So please do put in the correct name. And then it says you're registered successfully. So now when you finish playing the game, you will definitely get your certificate. The first screen is information about the patient. And here's our cute little kidney who's going to keep you company throughout the game as your progress is monitored by this kidney. Looking at the scene of the patient and the information given, there will be questions asked, and if you have given the correct answer, you will get a screen in this manner. But don't worry if you give a wrong answer. All you can do is try again. Once the game is over and you've successfully treated this patient, you will be congratulated and guided to a screen. You have to subscribe to the YouTube channel before you can get your certificate. So don't forget to subscribe. And remember to come back to the screen once you finish subscribing. So now our YouTube channel opens up, and definitely you should subscribe. Hit the subscribe button. When you come back to the original screen, you now will be able to download your certificate. Voila, here it is. You can either share it on LinkedIn and be a proud claimant that you've played the game, which is first ever designed. And you can also get the CRRT course for a very nominal fee. I'm sure even a samosa would cost more than this. So what are you waiting for? Play the game right now.
We have with us Lokinder Sharma today, and he has been one of my very diligent students also, and a helper also for the team. And he has not only been actively engaging me with my Instagram posts, but he himself has a very successful Instagram channel that is Expert Dialysis. He has done his dialysis technician professional course from PGI Chandigarh, and his knowledge is very amazing, just like my earlier colleague Karthik was from Amrita Institute. And I'm happy to associate with different technicians of you who are interested in learning and teaching yourselves. So, with this, I invite Lokinder to share his thoughts. He has played the game, he has even gone through our CRRT course, and I would like him to share some feedback about it. Good points, bad points, both are allowed.
Thank you so much, ma'am, for the kind introduction and for giving the opportunity to be a part of this wonderful event. So I played the game and it was fun, full of knowledge and a truly engaging experience. The quiz is focused on dialysis that challenges our clinical decision making, test real world knowledge, and encourages us to think critically under pressure. This is exactly the kind of engagement we need more in our medical community. It also brought out healthy competition and quick thinking skills in me. I genuinely enjoyed participating and seeing how creatively such a vital subject like dialysis can be presented. It was a refreshing way to learn, way beyond our natural, or we can say, the classroom of the ward experience that is a neat game. And I'm sure everyone, including myself, after playing the game, I felt a little bit sharper and more confident. About the CRRT course, I can say, I have to say, it was incredibly well structured and insightful. The practical use of theory in the real world was not accidentally there, making like the complex protocols feel very understandable and applicable in the real life. The balance between the lectures and demonstration was spot on, and the faculty was knowledgeable, especially ma'am and Karthik. They both taught us very easily there all the complex topics. Overall, the entire experience from the game to the course, I will say it is very thoughtfully planned and it's professionally executed. And I'm truly honored to have been invited here, not just as expert dancers, but as a part of growing passionate dancers community. I am looking forward to many more such meaningful gatherings. Thank you.
Thank you.
Thank you, Karthik. So we are finally here, and let me share a small behind the scenes fact about Karthik, that he was one of the most critical about the game when we first made it. And right from font size to colors of the fonts to suggestions about the language, he had suggested let's have a simpler language which is more universal. But we listened to some of his comments, implemented some of the changes, and some we didn't. So although he said many good things about the game right now, back then, about a month ago, he was quite critical. And I thank him for that because that was exactly what we needed.
So thank you very much for that, Loki.
So now let's begin the session that we have all signed up for, and that is the indications of CRRT. Dialysis professionals are day by day being engaged with this modality of therapy, and almost every ICU across has to have some form of renal replacement therapy, be it a simple hemodialysis machine or a complicated CRRT machine. There are many models, there are many types, there are many modalities of CRRT also, and all of these have been explained in our course, like Lokinder said. And it's a 20 plus sessions course, which you can do at your own pace, and you needn't worry whether you're going to finish it or not, because the course has a lifetime validity. But you do get a certificate which you can happily display in your resume. And as of today, Nephlearn is an independent entity, a private entity, but we have tied up with the RTMNU, that is the Rashtra Sant Tukaji Maharaj University, and we will soon be getting accreditation for some of our courses. And the first course that I am going to push for accreditation is this CRRT course. So in a few months' time, we will be having certificates which have a validity and a university recognition. So let's hope that we achieve that milestone soon. Coming to this topic, so we all know that renal indications, obviously patients with AKI in an ICU, CRRT seems to be the choice of therapy. But there are many non-renal indications also where CRRT can be used as an adjunct therapy, and not necessarily the patient has to have renal failure for this. So what are the common renal indications for renal replacement therapy? Particularly patients who have renal failure and are symptomatic. Either they may have oliguria, that is less than 0.3 ml per kg per hour urine output, or even anuria, or they may be having very high azotemia, that is the urea levels are sky high, or they may be having hyperkalemia, which is clinically symptomatic and shows electrocardiographic changes, and severe metabolic acidosis. The question is, when do we initiate the renal replacement therapy or CRRT? Patients of pulmonary edema, then patients of hyperkalemia and azotemia, as I shall explain further. Pulmonary edema is by itself a very important risk factor and has associated with a lot of mortality in patients of AKI with fluid overload. So pulmonary edema definitely is the number one indication, especially considering that the GFR is very low, that is oliguria or anuria. And in addition, the patient is given usually a lot of fluids in an ICU. There are IV medications, there are sometimes nutritional supplements which are parenteral. There are sometimes even replacement of fluids to, maintain the hemodynamic stability, and so on and so forth. Sometimes there are blood and blood transfusion related products. So many reasons why the fluid balance is more, but the fluid is not able to be removed by the body itself. So this is one indication. The second is hyperkalemia with electrocardiographic changes. This is definitely one indication because the hyperkalemia again similarly cannot be treated easily. And the third most important is the presence of uremic symptoms, especially uremic encephalopathy, which earlier we used to see as uremic flaps or asterisks. But nowadays it's no longer seen. Sorry for that word. So when do we actually start or implement the CRRT therapy? The Acute Kidney Dialysis Outcomes Initiative has considered that renal replacement therapy should begin in patients where the diuretic therapy fails. They are fluid overloaded and definitely cannot remove the fluid in the this thing which is there in the body. Secondly, these patients have a very low eGFR and therefore it is difficult to remove any fluid from the body. Also, like I said earlier, the patients need a lot of IV fluids. Even blood products are given in large quantities to such patients. And therefore, these patients should be considered for CRRT. But there are many non-renal indications also for renal replacement therapy, and these are the removal of drugs and toxins. So which are the drugs and the toxins that can be removed from CRRT? Well, it's mainly the drugs which have very high protein binding and therefore they cannot be easily excreted. And also the drugs which have a very long plasma half-life and therefore remain in circulation for a long time. These can be removed by sorbent hemoperfusion, and there are many filters available nowadays like cytosorb filters and others which can be used. But a word of caution, not all drugs and toxins need to be removed by CRRT alone. Even intermittent hemodialysis is useful in some of these. So CRRT is then preferable where the patient is hemodynamically unstable, and that's where the CRRT is the win. CRRT for removal of toxins and poisons is when the poisons or the toxins have a very large volume of distribution in the body and also have a high tissue binding. And there are some which have a rebound effect. So how much ever you remove the drug or the toxin or the analyte, it still causes a lot of rebound effect and starts to rise again and can again cause problems in the patient's body. And that's when CRRT can be used as an adjunctive to other therapies like intermittent hemodialysis or even chemoperfusion. So it may not always be used as a standalone therapy. Let us look at some of the drugs. Isopropanol can be removed by hemodialysis very effectively, but in cases where there is prolonged coma or myocardial depression or renal failure, CRRT is preferred. Similarly, ethylene glycol also responds to hemodialysis, but it should be continued the dialysis until the levels are less than 20 milligrams per dl or until metabolic acidosis has been resolved. But it is prone to have a rebound for up to 24 hours. Similarly, lithium can be removed by both intermittent hemodialysis and CRRT. Although intermittent hemodialysis removes lithium faster, but there is significant rebound, in which case you should consider CRRT. Methanol can also be removed by hemodialysis and should be continued till the serum concentrations are less than 25 milligrams per dl. or until the anion gap or the osmolar gap has been reduced or normalized. But this again has a rebound for up to 36 hours. Theophylline similarly can be removed by simple hemoperfusion, intermittent hemodialysis or CRRT, and should be continued till the levels are less than 20 milligrams per liter, but a rebound may occur. Valproic acid, again intermittent hemodialysis, CRRT or hemoperfusion can be used, but at supratherapeutic drug levels, the plasma proteins become saturated, and then the fraction of unbound drug which is there increases, and this becomes dialysable. So CRRT is then preferred because the fraction which is with the plasma proteins cannot be removed by simple hemodialysis. Direct thrombin inhibitors, hemodialysis, and salicylate poisoning, again hemodialysis or CRRT. There are an important set of investigations that every patient in an ICU undergoes, and this involves a lot of contrast agents. Earlier, there were high osmolar contrast agents which were used and which used to result in contrast nephropathy, which was associated with significant pulmonary edema. And this was difficult to treat also. In this situation, CRRT is useful because although it has a very low sustained effect of removal of the contrast agent, it still causes no rebound effect and it causes a gradual removal which is successful. Nowadays, however, there are a lot of contrast agents which have been developed which are no longer nephrotoxic, which have a low osmolar or even isoosmolar capacity, and therefore CRRT is not really required sometimes, and we no longer see contrast nephropathy so easily. But despite all of this, the recommendation is by experts that CRRT is the therapy of choice. Inflammatory mediators cannot be removed by intermittent hemodialysis, and for this you need special filters and CRRT like CVVH or CVVHDF. In both situations, however, if the patient has no renal failure, there is a controversy whether CRRT should be used or not used. Now, when do we actually start the renal replacement therapy or the CRRT? And there are three instances. The AKI trial network has shown that when the renal failure is symptomatic, when there is a fluid overload or there is severe hyponatremia or hypokalemia, the patient should be started on CRRT. And this early initiation of CRRT is recommended so that the complications do not develop into uncontrollable situations or difficult to treat situations. The other criteria is using the rifle criteria, that is the risk, injury, failure, loss and ESRD, or the AKI criteria, that is the AKI trial network like I just mentioned, in which stage 3 injury is considered as the indication of starting CRRT. And this is when the urine output is less than 0.3 ml per kg per hour for 24 hours, or there is anuria for 12 hours, or there is an increase of the serum creatinine in a very high copious amount. ARF, that is the failure stage, is associated with a 3 to 10 times higher risk of death, and this is where early initiation of CRRT is recommended. This is dicey because very often in an ICU, patients' relatives are asked for permission, and when they asked for the consent, they point out that the patient has not yet developed a very severe complication. But that's the whole point. You have to start CRRT before the patient develops very serious complications. And then when do we stop the renal replacement therapy? So these are the recommendations, that you measure the urine output, and if the urine output continues to be less than 12 ml per minute, then you continue the renal replacement therapy. But if it improves beyond 20 ml per minute, then we may consider discontinuing the renal replacement therapy. And this is based on the findings of the patient and the clinician's judgment. So the clinician's judgment also extends to selection of the patients that are going to receive the renal replacement therapy. First of all, like I said, patients with pulmonary edema, patients with risk of hypotension, patients who have cardiogenic shock or severe sepsis, or they have a low cardiac output, these are prone to hypotension. In addition, patients in the ICU receive large amounts of volume of fluids which cannot be removed by the body. And so to maintain the balance, CRRT is required. Imagine this, a single session of hemodialysis can remove at most 3 to 4 liters, and then there may be a rebound effect of again increased fluid overload. But CRRT can remove up to 7 liters, 5 to 7 liters in 24 hours gradually, and thereby avoiding the buildup of fluid overload in the patient's body. So CRRT would be preferable. Intracranial hypertension is an absolute indication for starting CRRT because during intermittent hemodialysis, the fluid shifts are so voluminous and so large that there is an increase in intracranial pressure or drop in intracranial pressure, and in this situation, it is unpredictable, and therefore the patient must be put on CRRT. Again, patients with severe fluid overload, especially those with AKI, with any cardiac abnormalities also, deserve to be put on a CRRT. And then there are the high catabolic states where the high stress of the illness, acute stress, itself causes a large turnover of protein substances in the body and causes very high levels of azotemia. And this is when the patient may develop encephalopathy and he needs to be put on CRRT. Patients on mechanical ventilation sometimes cannot be weaned off on the non-dialysis days, and that is the point where we can use CRRT. Also, patients with hyperkalemia who have electrocardiographic changes. So finally, which one should be used depends solely on the clinician judgment, on the patient selection, on the patient characteristics, on the associated comorbidities which are so large, on the urine output and the creatinine of the patients which should be monitored and measured, and early initiation of CRRT in the instances that I have mentioned above is very important, and early initiation of CRRT therapy can prevent development of complications which can be life-threatening. This will aid in early recovery of the patients rather than hampering the patients. Hemodialysis has its own role to play, CRRT has its own role to play, and it is up for grabs which one is better. Again, like I said, it's the clinician judgment and it is the situation of the patient in the ICU that will decide. With this ends the first introductory lecture that we have for CRRT essentials. We will be holding many more such lectures through live webinar. As my regular users, I would like to ask you a question. Please give us feedback about whether you like this live webinar format better or whether you like the webinar format better that we used to take on Zoom. In the case of Zoom, we would have nearly 600 applications and we would have a large number of participants, up to 400 in each webinar. And I used to enjoy teaching and interacting with people. So please type in the chat box if you like today's program, if you liked to see this. I think Mr. Hariragi has joined. No. Okay. So Mr. Hariragi was supposed to join us, but he is a little busy somewhere. He is the secretary of the Indian Association of Dialysis Technologists. And on his behalf, I would like to display that he has organized this IADT Con 2025. And this is the 5th national level conference of Indian Association of Dialysis Technologists, which will be held at Amrita Hospital, Faridabad on 20th and 21st September. And this is the first announcement. You can go to their website and register for the conference. There will be, this is the registration fees and the registration details. If any of you want, I will keep this open and you can log in for the registration form, scan this and use it. Friends, it has been a very happening morning and I would request that Priya and Lokinder join me, because lot to say actually, but there's very little time. And I have a lot to do. I have a lot of dreams, aspirations for dialysis, teaching and learning. Recently, we have tied up with, like I said, the Nagpur University PG Department of Teaching, and they will be happy to engage us in teaching and learning. I think there's a small technical adjustment being made by my side, and so I will just wait for this. In the meantime, yes, so all three are now seen, and yeah. So I wanted to point out here that we've been working a lot. Priya has been amazing. She has a lot of followers on Instagram. Lokinder also is similarly an amazing person to work with. And over the period of time, I have seen even Karthik, and there are many more of you actually who are so engaging with the teaching and learning, and you genuinely want to make a difference in the content that you deliver, and so on and so forth. I think Lokinder and Priya, would you like to say something to our viewers here?
Yes. First of all, I would like to thank you for spending the Sunday time with us. It was actually a great session from your side, ma'am.
Okay.
So, and it is a YouTube live. I think we got the good response on Zoom meeting. So we can arrange a Zoom meeting for the next session.
Okay.
Yeah. So because we are getting huge response on Zoom.
Okay.
Yeah. So it was actually a great session, and I would suggest our participants to keep the circulation of learning alive as mental dialysis runs. So they should upgrade their knowledge.
Yes.
I would request them to download this Nephlearn app because it is really a great platform to upgrade and to explore different topics about dialysis. Not just for technicians, but for nurses, RMOs, nephrologists. They can register. And the registration fees is not, it's really negligible. When we look after the course, there are so many courses like CRRT, and most important is for the RRP preparation exam. So those who are registered for the RRP exam, so they can subscribe to this course. They can register for this course. I think they will get the what they want, like MCQs and all other question answers. So that's.
Regarding the courses, it takes a very long time to actually do these courses. Designing a course is not simple. Lokinder and I have started working on one course together, but each time we start doing that, we are just wondering that okay, what's happening, because it takes a long time. So what I wanted to say here is that each course designing and developing takes a lot of effort. And then when you appreciate it and I get students on that course, I feel very happy that all the effort that I have taken is worth it and is useful. For me personally, it's a kind of philanthropy that I want to teach. So therefore the prices are very low. In one or two instances, I did try to keep the pricing a little higher, but I realized that no, the audience that I have is you, dialysis technicians and nurses, and well, it has to be easy on the pocket. Like I said, it has to cost the price of a samosa, not more than that.
Yeah, that's what I said.
Yes.
The cost is really negligible.
Yes.
And even you're offering discounts on courses like
Yes.
CRRT
Yes.
and RRP preparation exam. There are
Yes.
different offers going on. So I think we should register.
Ani, Lokinder, what would you like to say something? What about teaching, learning? What do you think should be more modalities of teaching and learning? How can we improve the things that we are doing?
Actually, the platform is very good. Actually, everything that we are doing is right on the track. But the thing that I feel which we might lag a little bit is we are not able to get in to the touch with the mainstream of dialysis technicians.
Okay.
I still know many people they are not aware
Okay.
about Nephlearn application. So
Uh-huh.
on that behalf we can do something.
Yeah.
But I believe that we are going to make a great change because at that time the courses that we are providing they are right
Uh-huh.
on spot and they are. I also tried them and I was the one to subscribe them from the
Yes.
very first time because
Yes. Yes.
uh, like Rita said, they are easy on pocket, and that's that's what the need of a student or a
That
dialysis
is true. That
right
is
in the
true.
time right now.
That is true. Uh, Again, I would like to thank you, Lokinder, because see, when you criticize, that's the best thing you can do for that person. See, what happens is it gives us as at Nephlearn a chance to improve. If I don't know that you don't like a particular color or the question is not right, or you feel there's some other answer to a particular MCQ, or you feel that some point has been written. Similarly, there are some students like Sanjay. He has asked me a lot of questions on the app. There is a chat option on the app in which you can ask questions. What is this answer? What is this answer? I feel this is the right answer. And it's really useful to come across students like these who are engaging, because then it gives me a chance to go back, review, maybe correct something, maybe ask them that no, your understanding is wrong, whatever it is. But I like that kind of interaction and it helps me a lot when you give me feedbacks. So, dear viewers, we will end the session with this today's feedback. And I encourage all of you to subscribe to our channel, to give us feedback really that what is happening, what you would like to see in the future, what you would like to do in the future. And with this, I think we will end our session with a big thank you to all our subscribers on YouTube. And do keep in tune and keep watching for more content. Thank you so much. Thank you, Priya, and thank you, Lokinder.
And don't forget to subscribe to Nephlearn.
Yes, that's what my team keeps telling me. Ma'am, you have to say this line.
Download the Nephlearn app as soon as possible.
Thank you, Priya. Thank you so much.
Instead of going through the book, it's better to subscribe for the or register for the interactive sections.
Yes. Thank you. Thank you so much.
Thank you.
Okay, bye everybody.
Thank you.
Yeah. Have a nice Sunday. किती झालं 14 फक्त व्ह्यूअर्स होते.